she came back and tissue looks a lot better. I've got good solid cores here, but I thought the tissue in this area was a bit fragile. It just seemed not as nice, shiny, pink, and healthy as this area. And I thought this was a result of, there's a root proximity problem between these two teeth. Whether I put splinted crowns here or two separate crowns here, this will always be a problem for patient management. And for us to manage in the office, once you get your crowns here, how is anybody going to clean effectively here? And I knew that would be a problem. So again, fixing it is one thing, keeping it fixed is another. So my thought ran towards removing this root. And this is just a previous picture that I've color corrected just for contrast so you could see it a little bit better on the screen. Here are the roots. In case you don't see it, there are the roots of that tooth. And this tooth almost seems to overlap the buccal of the second molar. So I thought if I could come in here, and as I said on another post, I do root resection in my office. Sadly, I hear it's not taught at schools anymore, but it should be. But root resection is a neat little trick. So here I thought if I could remove this root, it will open up this area and it will become an area that's cleansable and manageable over the course of a lifetime. So there you can see my thought process. So just going down with a burr, cutting down into this area. I couldn't do this at the time when I addressed the surgery, when I addressed this tooth, because I would have to go through amalgam at that time when there was a flap. And I don't want to use an air rotor on amalgam when I have an open flap. So I just started troughing down at this point, and that's just the gutta percha that's in the canal. So it's a welcome landmark. I know I'm halfway through when I've reached that. Just have to go a little bit further. I went through the furcation and I've delivered the root atraumatically. And there you can see a little bit of gutta percha from my endo. Now I have to manage the roof of the furcation. I can't leave an undercut in this area. So I'll come in with a fine diamond and I'll just start to dress this area, not touch the amalgam, but dress that area so that I've eliminated the undercut of the furcation. And this is just from a textbook where same tooth, just showing how this is done. Once you've freed up the root, you have to remove the roof of the furcation. So you come in with a burr and develop that shape. So mine's not as thinned out or as dramatic as that. Looks a little bit better than the typodont did. Now at this point, I did extend and grab the 24 as well. So these are the original 3-unit splinted crowns. And what I've done is I've hollow ground these 3, and I've added another crown to this unit, and I've picked up my finish line. So you can see this has to be recontoured because that is where the distal buccal root is. Now that I've removed it, I just have to recontour that area. And this is done at the time of surgery. It's flapped and then closed, cemented in, and it comes back a week later for suture removal. And you can see that it's starting to heal quite nicely. That little socket just has to go on to close, and then I can come back at a later date, re-prepare these margins, and grab an impression. And a few months later, that's exactly what happened. And now you can see the difference in the health of tissue from what it was before to what it was now. So now you should ask me about implants, because this is how it usually went.
Well, I actually have 2 questions.
Okay.
The first one is, this is a great technique that any dentist should have in their toolbox. But why did you choose to do it versus an implant? And the second one is, this is fairly complex, requires a lot of expertise. You've been doing this for a long time. Do you think a new dentist would be able to do this? Should they be able to do this? What do they need to be able to do this?
Well, you have to remember, when I look like that, I was a new dentist. And learning was different. We didn't have computers, we didn't have internet, but we had textbooks, and we had atlases of oral surgery. We had atlases of periodontal surgery, and like the knowledge is out there. You just have to have the inclination to find it. And sure, I can, at this stage of my career, I can cut down an entire arch with for crowns and not worry about it. But I didn't do that when I first started. I did one crown at a time, and spent a long time, because I knew I had a vision of what the perfect crown preparation is. They're in textbooks. What is the perfect crown preparation? And as I said, I'm a visual thinker. I'm a visual learner. So if I look at what it's got to look like, and I'm looking at the patient, I'll just keep going. And it requires developing tactile skills. You don't come out of school ready to roll on this, but you start slowly and you develop skills. You develop tactile sensation over the course of a few years, and then you just start tackling doing one crown becomes doing 2 crowns, 3 crowns at a time, a bridge, and you slowly develop. We had no mentors back then. You couldn't call a senior dentist and say, what do I do? Because they'd yell at you and say, well, we taught you this at school. How did you get doctor in front of your name? How did you graduate? It was there. Now we've got mentorship programs. We've got this platform to disseminate knowledge. But you still have to internalize it. And each new dentist has to answer this for themselves. Do you want to grow, or do you just want to stay the way you are once you've graduated? So I really, doing this, I learned this on my own. I took good courses at the time. There was perioprosthetics. There were some good courses in that, where it taught you to dovetail periodontal surgery with prosthetics. And that's just how I learned to do this. So I can rely on my experience to know what outcome I will have before I start. Now, I hope I've answered that question.
Yes, you did beautifully. My first question to you was, why go down this route versus...
I'm sorry I answered them in reverse, but I will answer them. Implants. I make the statement to patients. When I'm doing crown and bridge work on teeth, I pretty much know before I start how I'm going to end up. Before I pick up a drill, I know how it's going to go. Implants are a different story. The implants do heal, they don't heal. They're put in at the right angle, the angle's a little bit off, you have to fight for emergence profile. For me, implants are a last resort, not the first resort. One might say, well, this is expensive. Well, you haven't seen expense until you dive into the realm of implants, where a lab bill can be $1,000. I just got a lab bill for a single crown. It was near $1,200. In terms of cost and in terms of time efficiency, this patient is never without teeth. This patient did not have to go through sinus lifting. This patient didn't have to live a year and a half without teeth where she couldn't manage. So never without teeth. She has a functional occlusion. She comes to my office, leaves my office, and she can carry on as she always has. So as far as I'm concerned, if I can, and she had nice long roots, so I could do this. Obviously, if this was a perio issue, the roots had a poor crown root ratio, et cetera, all of that is distilled. All of that is thought about. In this case, I thought the roots are robust and long. As I said earlier, if I have good crown form, if I have good root form, if the roots are strong, the perio is good, then you can do this sort of thing. So that's why I didn't go the route of implants with her.
So
That's a whole
basically,
different can of worms.
yeah. So basically, she didn't really need them, and it was the tooth was good enough for you to work on it and not to lose it, for that matter.
The important word in your question is need. That's a relative term, and everybody defines that differently. I knew that I could end up like this. I felt confident. So that's why I went this route, because I've done this many times. So I'm not asking other dentists to go ahead and practice how I'm practicing, but it's something that it would be a nice idea to be exposed to.
All right. So how did the treatment of this area
Okay.
complete?
So with tissue that's pink and healthy, this greatly facilitates impression taking. Whether you're doing this as I do it, VPS impression material in a custom tray, or you're doing it digitally, having pink healthy tissue with margins that aren't buried under diseased skin just facilitates accurate impression taking. And if I want to make restorations, and I have to supply my lab with a perfect impression. So here you can see it's about as perfect as I can get it. There's no defects, there's nothing. All the margins are clean and crisp. And this is just one of the details of getting it right. As I've said before, dentistry, if it's off by a millimeter, it might as well be off by a mile, because it'll fail. That's from the lingual aspect, those margins. So once I've re-prepared the teeth to get that impression, I've secured my impression. Now I'll just take those 4 splinted crowns and I'll hollow grind them. These are the provisionals. I'll add some flowing U-methyl methacrylate, pop that onto the teeth, and what I've essentially done is impress the margins very accurately in this material, as I have in my impression. And again, you can see I've added some impression material again just to keep the stone away from the margin. And then I go on to carve that using sandpaper disc and an electric handpiece and trim everything away to define an accurate margin, because that drives and maintains the health of tissue. At any point, if you have a provisional which is not done properly, it will affect the health of the soft tissue. So we're here at August 2015.
Dr. Belzicki, I think we should have a post at some point in the future about how you carve those provisionals.
I think I did. I took a little video of it. It's kind of hard for me to do that, but I'll try. Anyways, I've got my 4 crowns here, and my design would be to have 2 splinted crowns here, because these 2 teeth are endodontically treated. And I don't want them to move apart, and I just want strength here. And then I would put 2 splinted crowns here that are separate from these 2. Because that's a small little runty kind of crown. And I thought if I could just tie these 2 together, there's strength in numbers. So again, I get all the metal copings back separately. And there you can see how clean the lab works. I still like a stone model. I know it's called organic now, but I still like a stone model. I need to have that for my comfort level. I don't like doing things digitally. This design, my lab and I have developed over the course of time. It took a while to get them to come on board. But I want good, long surface areas for my solder, for the solder joint. And these are inserted. I just call these metal struts. They're just extensions of the metal occlusally that will be in contact with the lower arch. I find this is advantageous and important when you're doing crowns in the posterior where you've removed all of the occlusal stops. Those provide a nice landmark. So again, here's the tissue. I'll be trying in those metal copings. The skin in this area continues to heal and mature over time. So the copings are tried in. This will bulk up later on. Remember, this was an extraction site, so the bone still has to come up a little bit. These are tried in, checked for accuracy, and then I tack them together with just methyl methacrylate. I could use the red Duralay that I have also in the office. I was bringing this tooth out buccally, just so it would look a little nicer, wouldn't have a dark shadow here. So I send a little note to the lab, please check if there's sufficient metal for support of this cantilevered cusp to support that porcelain. So I have to be responsible for everything. Lab technicians are great, but they're just lab technicians. And I'm responsible for it all. So here you can see the metal, these little metal struts will just be touching. I like them a little bit long so I can put it in the mouth. After I do my solder indexing, I'll just adjust the metal down so the patient feels that the bite is level. And that's the landmark that the lab can build the porcelain to. And here the porcelain comes back. So these two have been soldered together. They're two splinted units, and there's a separation here. Fine metal band going interproximally. Having the lab follow the contour of my provisionals. And there you can see it. Again, I've probably adjusted here a little bit more once I got it back to make sure that it was open enough for the patient to clean in between. So here you can see there's a continuity in the shape and the contour. This design is developed by me in this phase of treatment because this is proven to maintain the health of tissue. So I don't want the lab to give me something else. Give me what I've made, please. And this is the day of insertion, October 2015. And sometimes I'll have the lab reduce the metal if it's an aesthetic issue, and I'll have that in porcelain. But in this case, I just left the metal exposed. It serves as a good landmark for me. And embrasures are nice and open, easy to clean in between. That cusp got cantilevered outwards, so it looks like a smile. Looks nice when she smiles. Again, where aesthetics are concerned, porcelain over metal. I don't like porcelain butt joints. I like porcelain over metal. And here, fine metal margin. Nobody sees back there. Or at least in this case, you didn't. And there's the radiographs, or the radiograph. And you can see, going back to that other case of that gal from Quebec, there's a fit and finish. These margins are spot on because I had to fight for them. It wasn't easy. She came in, I have pain upper right. Okay, well, I've got a little crack in this tooth. Yes, there's an open contact, but the tissue isn't a problem there. And I've got cracks in these two teeth. And what's termed micro leakage, I guess. I mean, this doesn't scare me all that much when I see this around old restorations. It's just self-sealing of the amalgam. But I picked this tooth to work on, probably because of biting pressure, or I may have just used some cold spray, and we elected to work on this tooth. And I told her, it could be this tooth, could be another tooth, but let's work on this one first because it needs treatment. So here you can see a small little break of the marginal ridge, a crack here. Again, just different views. So I started taking this tooth apart, and lo and behold, there was an occult fracture running through the middle of the tooth. And given the symptoms, elected to do endo. So there's the endodontic treatment being performed. Again, having photographs of what these teeth look like throughout the course of treatment, I find is invaluable. So
What was the extent of decay under the amalgam? Did you find any?
no, no, and I wasn't expecting to either. There was a little bit here, but it was here. You can see the color of the dentin. It looked good, but again, fracture, heavy bite. Patient just has a heavy bite. You have to remember she's over 50. This tooth has been functioning for some 45 years since it came in at 6. So that's a lot of service for a tooth to give. So I just restored it with some combination of materials, got my isolation, then did the endo, and then it just closed up the access. So she came back, and I elected to prepare all these 3 teeth for provisionals. I was going to put crowns on these teeth, and then I noted a crack here. And I believe I went on to do endo there as well. I don't have a photograph of that, but I believe she came back subsequently and said, there's another tooth that's bothering me. So I believe that tooth had to have endo as well. So here I am preparing tooth structure, and I made provisional crowns. Sorry, I don't have any other photographs of that right now. And then she came in, just let me check that date. So that was December 2015. In January, I've got pain from the lower. And this film happens to be from 2013 on original presentation. You can remember that there was a little bit of that chewing gum that was there. But before I started in, this is what the tooth looked like. And taking the restoration apart, there were a lot of problems here. And getting down, we did end up in the pulp chamber. And once I got rid of the entire restoration, not a lot of tooth structure left. Endodontics was done. And there you can see my little endo treatment. And the tooth was restored. I think I put an amalgam restoration in at the time. And then I went back 4 or 5 months later. I came back to the upper first quadrant, got my impression for the crowns. And here we just went with 3 separate crowns. And these 2 are zirconia. Thought I'd give that a try. So on presentation, day of insertion, again, with good provisionals, respecting the margins, making sure the contour is correct, the tissue is picture perfect. So cementing these crowns in is uneventful. And then we came down to, so going back to this tooth, I just took an upper arch. And again, going back to what I said before, vision. When I first started, I had that vision of that other patient, and yeah, I don't need to do these teeth, but I've secured the molar areas quite nicely with crowns. About a year later, after I had done the endo, she was ready for me to start restoring this tooth. And I thought, well, I'll put a crown on this tooth as well because it's pretty much beat up also. So getting into this tooth, there was another crack that was noted at the time. And again, when you take photographs, you can present this to a patient and say, look, when I have my loupes on, this is what I see. This is how your teeth look. This is a significant crack. We have to address this. That goes a long way for patient acceptance, informed consent, rather than saying, I see a crack, and you start working. I work with, there's a camera in every operatory, and I'm constantly taking photographs. My patients often make fun of that. But I just find this the best way to transfer information. I don't feel like I'm talking anybody into anything. You have a crack. You want me to fix it? You don't want me to fix it. You decide. But don't come back later if you've asked me to put an amalgam here or composite or whatever restorative material you want to use, and then say now you made it more sore. You have a problematic tooth. So we addressed that, made my crown preparation, and I sent her away after I made my provisionals, and she did come back saying the tooth is now hyper. Well, there's good reason for that. That crack is going down, and I probably took a tooth that may have been on the borderline, and doing my crown preparation, imparting energy into this tooth, I probably took a sick nerve and pushed it over the edge. So I had to do endo for this tooth as well. So again, going back to splinted crowns, getting the thimbles back, tacking them together in the mouth, a little bit of lab work, taking a bite. Sometimes I'll mount them in the office. I find it more accurate than if my lab does. And then I get the crowns back, splint it together, fine metal margin, and tissue looks, again, picture perfect. Making sure that there's a good embrasure space for cleaning, and those are cemented in. And I thought I was a winner, off and running. So that occurred the last time I worked on her was a few years ago, but she came back just recently. Doctor, I got swelling in the upper left quadrant. And I thought, you're kidding. And she said no, and she was swollen and tender. So I went back to the radiograph I had from 2014, and that's the current one, 2019. This occurred in January, February of this year. And pinned it down to, and it's hard, once they have splinted crowns, it's hard to discern if they do have a problem, which tooth is the offending tooth. Because if you bite here, well, you're stressing that one as well. But I sent her off to my colleague, who you've seen before on the series of presentations, Dr. Monkars. And he said, Paul, I think we've got an active lesion here, and we have to redo the endo. And I thought, damn it, so I gave him all the images I had beforehand, what I had done to the tooth, so he would have an idea what's gone on in this tooth, what's the history of it, so he could see, look, there's a post here, there's some composite resin, I ended up doing this, and now you've got to do your thing. And I told him, I'll give you license if you want to. I'll remove the crown from this tooth. You do what you have to do. Get the post out, get everything out. I'll remake her two crowns, no cost. He said, Paul, let me see what I can do. And what he did was, working through this small opening and, skills. My old professor, Blake McAdam, said dentists, we're all created equal. Some are just more equal than others. I love that phrase. Well, the fact that he could get out a post, auger out the composite resin, refill those canals through such a small opening, it blew me away. And I was able to just put a little plug of amalgam in there. And she's off and running with the same crowns that I had put in back in 2014, 2015. And you can see how the tissue has come up quite nicely. That socket had healed. So hopefully this will not be a problem, and she'll carry on. So that's what I meant about, I wanted to err on trying to conserve costs. The tooth was asymptomatic. She had told me that endo was done previously by an endodontist. So I thought, well, I needn't worry about that once I got rid of the decay on that tooth. But again, the canal wasn't as cleaned as nicely as it could have been. Or bacteria have a way of getting in and around composite resin, probably traveling up the post, and there was just reinfection of that. But we were able to manage a conservative fix.
Well, amazing, beautiful craftsmanship, I must say, but also beautiful collaboration between you and Dr. Moncars. And yes, he was on Oasis previously. I will have a link to his presentation on this post.
So this patient, as I said, managing it in segments is kind of neat. You can break up costs, break up treatment. When you manage it in segments, you don't lose landmarks of occlusion. Sometimes cutting everything down, doing everything at once, there's always the fear of the occlusion going off. So if I can keep them comfortable doing it segmentally, that's far easier for the patient and far easier for me.
So to wrap it up, Dr. Belziki, what are, if you can think back to the whole case, what are 2 or 3 main points that are very important to consider?
I've said dentistry is a tough gig. Yeah, you can make it simple by not looking and just doing it. Hey, it's the best I could do, and that's that. But if you want to provide long-lasting restorations, you have to fight for every detail. If there are 10 steps involved and you do 9 perfect and 1 not so great, it will come back to haunt you. So it's not that it requires a lot of brain power, and it's not that anything is overly difficult. It's just a lot of simple tasks need to be executed to an exacting manner to end up with a good restoration. What I've presented, if I can do it, I was just a solid B student. Back then you could sneak in with a solid B. If I can do this, anybody can do it. It just takes a lot of dedication, hard work, and not working towards a time schedule. If you've only allotted X amount of time to do any procedure, simple or complicated, and you run into a problem, you say, geez, I have Mrs. Jones next door, I got to get rid of Mrs. Smith. Something has to go. Something has to yield, and it's usually the precision with which things are executed. So you have to know what the ideal is. You have to struggle towards that, and you have to leave enough time for the struggling to take place and realize that it can be frustrating trying to get a margin on that 27 where there's bleeding, there's blood, you drill a little bit, you wash, you look a little bit, going back and forth. And I may have spent 30, 40 minutes on just that one margin on one tooth, because that's what it took for me to see, isolate it, and develop a solid crown afterwards. So that's one takeaway, is that nothing happens simple. If you buy into digital dentistry, just go in, take a picture, zap, 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 and the computer spits it out, and here it is, and throw it in. Good luck, because you have to struggle there too. I don't know what all the ins and outs are of that because I don't practice that way. I have had CAD/CAM computer milled or computer generated bridge work done for implants and things of that sort. You have to fight there too. There's drawbacks, there's problems there too. I don't know what they all are. I haven't bumped into them. I've bumped into a few, and I know you still have to fight. You still have to struggle with the technician or Straumann's or Noble Biocare, whoever makes it. You still have to give direction because you're the dentist, and you really can't expect to accept everything that comes to you that it's going to fit perfectly.
Dr. Belziki, I don't know how to thank you, really. But
thank you.
I'll say thank you. Thank you very much for taking the time and making the effort to be here early, very early in the morning to tape this presentation. I know how much effort and time it goes into all of these. I really appreciate it, and I hope to continue to host you on Oasis.
Okay, thank you. Bye-bye.